and I am an advanced emergency medical technician. I am also a part-time instructor at the PHEMS Institute. I'll be covering the presentations for this morning, and we will continue to look at the trauma chapters. So we'll be covering the next 3 trauma chapters, starting with face and neck injuries. I hope you have all had some rest yesterday and have revised your material and are all prepared to continue with the chapters. So we'll move right into face and neck injuries. Are you hearing me clearly? Just indicate by a show of hand if you are hearing me okay. Okay, thank you. So as we start face and neck injuries, face and neck injuries are frequently subjected to traumatic forces. And this is so because the face and the neck are 2 of the most exposed area of the body, and so they are likely to be impacted traumatically. Soft tissue injuries and fractures to bones are common and vary in severity. Some injuries are life-threatening, and you will find in case where you have penetrating trauma to the neck may cause severe bleeding. Also, an open injury may allow an ear embolism to enter the circulatory system. In case you have trauma where you have a open appear in the trachea or access to air into the jugular vein, then you can have air being sucked into the circulation, goes to the heart, and then you can have an ear embolism, which is a life-threatening situation, potentially. So what are our objectives when we are treating a patient with a face and neck injuries? These are the things that we will ensure that we are looking out for. We want to prevent further injury, particularly to cervical spine. So once you have an injury to the face and neck, your high suspicion should be there of cervical spine injury, and you need to take the appropriate precautions. You want to ensure that you're managing any acute airway problems, and you will see that coming up out of our discussion as we go forward. So it's going to be your ABCs will be your focus with these injuries, as in general patient assessment. You're going to ensure that you control any bleeding. With any system you are dealing with, you will need to have an appreciation of the anatomy and physiology of that system. As the main focus for us as we are looking at trauma will be the pathophysiology, but you need to have an appreciation of anatomy and physiology, and you would have looked at this as it relates to face and neck when you did the human body. So this is basically a review. So you must know the structures that you are dealing with as it relates to the face and neck. The landmarks, bone and landmarks, the head is divided into the cranium and the face. Overall, the body have 206 bones and the face comprised of 14. The face is composed of ears, eyes, nose, mouth, and cheeks. So you have to have an appreciation of the structures that are involved. So ensure that you have an idea of the face. You will have your nasal bone, the zygoma, which is your cheekbone, the maxilla, which is your upper jawbone, and the mandible, which is your lower jawbone. As we continue with the anatomy and physiology, as it relates to the neck, you must know the structures that are there. So these are the structures that can be impacted when we have trauma to the neck. You have the thyroid cartilage, which we know is your Adam's apple. Below that, the next structure we'll see is your cricoid cartilage. And between the thyroid cartilage and the cricoid cartilage, there is a membrane. There is no bone or cartilage there. It's the cricothyroid membrane. So we'll see further how that will come in certain instances. So below that, you have your trachea. You have to have an appreciation of these structures. You see also involved in the neck region, you will also have the muscles and arteries. Also, you'll have the veins. Know the structures, and so you'll have a better appreciation when there is trauma, what structures are impacted and how they will affect how the patient will present and guide your management. As I said before, anatomy and physiology should have been looked at earlier on, so we are not going to be spending much time on that. We want to get to the pathophysiology and signs and symptom treatment. That will be our focus, but this is just a review. So as we look at the eye, it's located within a bony socket called the orbit to help to protect it and maintain its shape. You have it being supplied with the oculomotor nerve, which innervates the muscles and carries parasympathetic nerve fibers. So this is the nerves that allow the eye to move, but also you have the optic nerve, which provides a sense of vision. So the optic nerve is what's going to be responsible for the interpretation of the vision. And you will see in the diagram that you know the areas of the eyes, especially focus on the retina, and you see where you have the optic nerves coming in. Again, like I said, it's a review, so you can pay more attention to it as you go on. So the inner surface of the eyelids and the exposed surface of the eye are covered by the conjunctiva. So the conjunctiva is the lining of the eye. The opening in the center of the iris is the pupil. So this is basically anatomy. Know those structures. The ear, a complex organ that is associated with hearing and balance. So you need to recognize that you have three divisions to the ear. You have the external ear, the middle ear, and the inner ear. Most of the time you will be dealing with the external ear or the outer ear, where you have the pinna, and that's what's going to be impacted when we have trauma. You also can have impact to the tympanic membrane, which is known as the eardrum. But further inward, there's not much you can do as it relates to the inner ear and more so the middle ear, but the patient will exhibit signs and symptoms which you will need to recognize is coming from an ear injury. So we get to the main area of focus for you as advanced EMTs, and generally you will need to know pathophysiology, what's injuries involved as it relates to face and neck, and signs and symptoms and how you will treat with them generally and specifically as it relates to each individual injury. Injuries of the face and neck can often lead to partial or complete obstruction of the upper airway. You need to recognize that this is a high possibility and take the necessary precautions and action. Several factors may contribute to obstruction. The direct injury to the nose and mouth. You have bleeding from these areas. You have loss of the structural integrity of these areas, which can contribute to the obstruction of the airway. Injuries may cause teeth or dentures to become dislodged. Again, this is a potential area of obstruction. Swelling that accompanies direct and indirect injuries. All these can contribute to airway obstruction, upper airway obstruction, and you need to focus and be mindful of them. Soft tissue injuries, face and neck, are extremely vascular. So these areas are profuse with lot of blood vessels. Therefore, bleeding from penetrating injuries may be heavy. Also, you need to recognize that these injuries can look ugly, awful, and they can tend to distract you from the real life-threatening situation of the patient. So again, don't be distracted from the sight of these injuries, but your assessment focus on what will kill the patient immediately, which will be the airway obstruction, the compromising of the breathing, and the circulation issue. So yes, the bleeding will play out in the circulation, but not just be distracted by the awful sight of the injury itself. So presence suggests the potential for more severe injuries. That is what you need to be mindful of. What are the dangerous or life-threatening injuries that are there from these that you are seeing on the face and neck, even an anterior aspect of the face and neck? Think about what can be underlying damage that is there, life-threatening. So you will ensure that you maintain a high index of suspicion when a patient presents with close soft tissue injuries to the face. Remember that the blood is a gastric irritant. So if the blood gets into the gastrointestinal system, then it will cause irritation and promote the vomiting, and that's the danger with the vomiting, potential for aspiration of abdominal content, and so it can be a life-threatening situation. So always have that index of suspicion once the person or the patient has a closed soft tissue injury, and even open soft tissue injury, it's a potential that underlying structures and system can be impacted. Facial fractures. These occur when the facial bones absorb the energy of a strong impact. under normal circumstances are minor injuries. They can withstand certain forces, but beyond that, they are going to be compromised and result in injury or fracture. Protect the cervical spine and monitor neurologic signs, specifically the level of consciousness. Always be mindful of it. If the mechanism of injury suggests that it's significant, then you're going to be thinking of spinal injury and take necessary precaution, and the patient's neurological status will be compromised. So check the person LOC, mental status. General signs and symptoms from facial fractures you will see and hear are deep facial laceration, pain over a bone, ecchymosis, swelling, pain and palpation, crepitus, misalignment of teeth. And for misalignment of teeth, another word they have is malocclusion of the teeth. So the upper jaw compromise or the lower jaw compromise, and the teeth are no longer in alignment. When a person closes their mouth, then they are not lining up one to the other, upper and lower are not aligned. All of these, if you see one of this sign or symptom or combination, have a high suspicion that facial fractures are there. You can also have fractures of the nasal bone, and it's going to be characterized by swelling, tenderness, and crepitus. So these are all part of your DCAT DTLS, or under we have a shortened version, we call it DOTS. So once any of those are present, suspect a nasal fracture. The bone, the nose can be deformed. If present, usually appears as a lateral displacement of the nasal bone. So it's no longer in alignment. You see the lateral displacement, then you should suspect. Unless the person had an injury before and it was healed and it's like that, then you should suspect in an acute case that this is a new nasal fracture. Often complicated by the presence of an anterior or posterior nosebleed. So either the person is bleeding on the outside from the nose or nostrils, or they can be having an interior bleeding inside. So it's a posterior bleeding. You will most of the time miss it unless the person, you're looking inside the mouth and you notice bleeding from the inside. So it's all about your index of suspicion. From the MOI, you should suspect that they could be bleeding from the inside posterior. So have that index of suspicion. For the mandibular fractures, and we say that the mandible is the lower jawbone, so it can become fractured. Typical results from massive blunt force trauma to the lower third of the face. So it's gonna take significant force to fracture the mandible. And once you notice that, then you should be telling yourself that this patient can have other underlying injuries and complications just from that injury that you see to the mandible, which gives you an index of suspicion for a fracture. The fracture site itself is most commonly located at the angle of the jaw. So that's the temporomandibular joint, because the force is gonna be transferred to the point of least resistance, and that's where it's gonna have, and that's where the movement takes place. So point tenderness and pain and motion can identify injuries that the patient might not have otherwise reported. So they might not even realize it, but when you are doing your assessment and your rapid scan and you're palpating, then they would tell you that they are feeling pain there. And so you're gonna have that index of suspicion that the mandible has been fractured. So the mandibular fractures can present in, basically are classified as in three groups or three types. and it, as we said, occur in mechanism that produce massive blunt facial trauma. So the first type is Lefort 1 or Lefort 1. In this case, the fracture occur across the hard palate of the mandible and right below the nostril or the nasal bone. With Lefort 2, it's gonna be occurring above the nasal bone, and it's in a pyramid shape. So it's below the orbits but above the nose. It's right at the nasal bone, and it gives you that classic pyramid shape. With Lefort 3, it's right across the mid-facial bone. So you actually have a complete separation of the face from the cranium. So with all, they will normally present with what you call elongation of the face. So it's like it causes the face to drop down, so to speak, and you can see that classic presentation. But out in the field, it's not really us to identify which type it is, but just to recognize that it is a possible maxilla fracture. And so we need to do what we need to do and recognize that it can have underlying complications. As it relates to the eye, orbital fractures, signs and symptoms may include double vision, and that's diplopia, loss of sensation above the eyebrow or over the cheek, paralysis of upward gaze, and all of this is a result of where the fracture has occurred. Massive nasal discharge may occur, and vision is often affected. So if the orbit is fractured, then it can affect the movement of the eye and cause damage also to the nerves. So vision can be affected and movement of the eye. So all of those are signs and symptoms coming out that you should suspect a orbital fracture. Zygomatic fractures, and we say the zygoma are the cheekbones, commonly result from blunt trauma in motor vehicle crashes and assaults. And the signs and symptoms we will see and hear: side of the patient's face that the fractures appeared flattened. So again, it's as if it has dropped down. Loss of sensation over cheek, nose, and upper lip, paralysis of upper gaze. All these are signs and symptoms that should suggest to you that the zygoma has fractured or is fractured. Dental injuries, injuries to the teeth, may be associated with mechanisms that cause severe maxillofacial trauma, or they may occur in isolation. So it could be from the upper jawbone or facial bone fracture injury that results in the dentals or teeth being impacted. Always assess the patient's mouth following a facial injury. Again, the focus is gonna be ensure the airway is patent. Teeth fragments can become an airway obstruction and should be removed immediately. Leave well-fitting dentures in place, and we want to do this to maintain integrity, the structural integrity of the oral passage, so that will help us in case you need to ventilate the patient. If you need to put in an airway adjunct, it will help in that process to maintain that structural integrity. But if they are loose, they can become a hazard, and so loose dentures should be removed, and you should have that index of suspicion. If you look in the person's mouth and you observe teeth missing, then if that's not what they were like before, then you should suspect that where is the teeth that gone down or tooth and can become an issue. So be mindful of that. So we have looked at the anatomy, physiology, and the pathophysiology of the facial and face and neck. Now we are going to be looking in general at patient assessment, and patient assessment will always be patient assessment generally. So you will always start with your scene size up, and with scene size up, every scene you go on, every scenario you're gonna do, whether in class or in the real world you go on a case, remember, safety will always come first. So safety for you, your partner, or partners, then the patient, family member, bystanders. That's how you're gonna go with safety. But safety gonna be personal at first. So ensure you are safe. Otherwise, it doesn't make sense to go any further. Assess. So observe for hazards and threats to the safety. Assess the impact of hazard and patient care. So what is there on the scene that will affect me and how I will be able to deal with the patient. Take standard precautions that require eye protection and a face mask, and we would, under the new dispensation, ideally you should be looking at the mechanism of injury since we are dealing with trauma, but generally mechanism of injury or nature of illness first before you finalize what standard precaution or body substance isolation you need to take, because it all depends on what is happening on the scene, which will determine overall what standard precaution you take. So if you had put on at a minimum, you're gonna start out with your gloves, eyewear. In this case of COVID, you will have your face mask, but at a minimum, you will start with your gloves and your mask. But depending on what's happening, you might have to go up to your eyewear, gown, and the whole work. So look at your MOI first, then you will see what you need to finish up with. You need to determine the number of patients as a part of your scene size up, and you need to consider spinal injuries if we are looking at the MOI, which is significant as it relates to face and neck injuries. Then you will consider if you need any additional resources. As an advanced personnel, then you would need to know if you need to call paramedics if based on the case that you are dealing with. You need to make that determination from your scene size up before moving forward, because once you have moved into your next level, which is your primary survey or your primary assessment, then you'll be caught up with what's going on, so you won't have time to do what you should have done in your scene size up. So primary survey as it relates to face and neck injuries and more in general focuses on identifying and managing life-threatening concerns. So your goal of the primary survey or assessment is to find and treat those immediate and potential life threats, and you want to find those immediate and deal with them right away. You're going to always be assessing for readily apparent life threats. Combative or aggressive behavior can be a sign of a closed head injury. So you're going to start out first with your general impression, and from the general impression you would have gotten an index of how the patient appear to you. So if the person appear combative and aggressive, it can be a sign of closed injury just from looking at the patient in your general impression. You're gonna ensure that you check the patient's LOC, so always check for responsiveness using the AVPU, and we all know alert, whether they are alert, they're responsive to voice or pain, or ultimately unresponsive. You're gonna suction any blood, fluid, or vomit until the airway is clear. Once you have assessed the LOC, once you have gone to your life threats immediate ABC, and we said before it's gonna be A, B, C, D, E, and if there's severe bleeding, then it's gonna be X, A, B, C, D, E. So deal with that exsanguinating bleeding, then you focus on the airway, breathing, circulation, and then you will go to your disability and exposure. So that's gonna be your order, and every situation will be unique, so you need to deal with the situation as it is presented. As we continue with the primary survey, remove teeth fragments from patient's mouth without a delay. As we said, this can become an obstruction of the airway. Therefore, it has to be dealt with. Quickly assess for adequacy of breathing. And if in managing the airway, once there is what you call gurgling sound that suggests fluid, so you need to suction that patient, turn the patient as a unit if you suspect spinal injury, and drain whatever fluids, then you need to suction. If you hear snoring, then that's a positional issue, so you need to open the airway, just if you suspect spinal injury. So you need to quickly assess the adequacy of breathing. Therefore, you need to check ventilation for upper airway if it's adequate, or you need to manage it, and lower airway for oxygenation issue. And as an advance, you expected to have your cardiac monitor attached, and you need to check the end-tidal CO2 of the patient along with your O2 saturation. So you need at a minimum, we want to be using capnography reading. Call early for paramedic backup, and again, you would have an idea from the beginning and in your scene size up. If you didn't realize it from then as soon as you realize the need for that paramedic backup, then you need to initiate it. Avoid delays in transport and consider paramedic backup or air transport if the transport time is long. So if you recognize that the patient has been down for a long time and there might be a motor vehicle accident scene and the patient is trapped and take a long time to get that patient out of entrapment, then you know that the time, as we look at the platinum 10, you want to have that patient removed from the scene within 10 minutes once there is significant trauma for them to have the best possible outcome. Therefore, you should have that index of suspicion, and if your jurisdiction allows it, then it all depends on where you're working, where they have the possibility for air transport. But once you recognize it's needed and it's available, then you need to activate that, call for it. Provide rapid transport for any patient who presents with signs of hypoperfusion, significant mechanism of injury, but in stable condition, poor general impression, abnormal vital signs, and dyspnea, difficulty breathing. So all of these suggest that once there is any compromising of the ABCs, then you need to recognize that this is what we say, we are load and go patient, and you need to package that patient after you have done your assessment and provide the appropriate treatment. You need to be getting that patient off that scene. With trauma injuries, the patient ultimately gonna need some surgical intervention in severe cases, so not delaying that is the best you can do for the patient. After you have completed your primary survey, so you have done your scene size up, you have gone through your primary survey or primary assessment, then you're going to be focusing on your history taking. And as advanced part of your circulation and treatment in your primary assessment, you would expected where needed, you would establish IV access, and if the need needed, you would give your fluid administration. You still can monitor. Just be mindful that a patient can have a trauma and it is a result of a medical condition. So again, have that index of suspicion when you're asking the questions in your history. What happened before the trauma is a good response that will indicate to you. But you might still have to connect the patient and maybe get ECG reading and so forth. But your third stage of the patient assessment would be your history taking. And as it relates to face and neck trauma, you're always gonna investigate the chief complaint. What is happening now? OPQRST of the chief complaint, and then you will go to your sample history, which will give you information on what was pre-existing with this person, what led up to this that is happening to them now. But always get your chief complaint investigated first, and you're gonna use your pneumonic OPQRST as a guide, and be alert for injury-specific signs and symptoms. In your sample history, attempt to gather from friends or family if the patient is unresponsive. Information may or may not be accurate and may be incomplete, but at least you try to get something. Don't tell yourself that the patient is unresponsive and I cannot get any history. You can also check the patient if the patient has any medical alert bracelet or medical card, and if you are checking the patient wallet, ensure that possibly your partner is there, so you can't be accused of anything untowards. So after your history taking, it's gonna be your secondary assessment, and with trauma, as you might not be able to get much history, so you get whatever history you can get, but you will do your secondary assessment. Again, you deal with the situation as it presents itself. You can tweak it, maybe do your secondary along with your history if you have the appropriate personnel, but may ensure that you are doing your systematic approach. So for your secondary assessment, if significant trauma has likely affected multiple systems, perform a rapid body scan, look for DCAP DTLS. Normally, we would bring up the rapid scan into your primary survey or primary assessment after you have done your ABCs. Then you would complete it by asking yourself the question, is this mechanism of injury significant that you need to do a rapid scan? Or if it's not significant, it's a localized issue, then you would focus your assessment when you reach to your secondary assessment. So in most cases, you would have done your DTLS rapid scan at the end of your primary assessment or survey. So be mindful of that. Do not delay transport to complete a thorough physical examination. So if you have a patient who has airway or breathing circulation compromised, and you are focusing on those life-threatening situations, you might not have time to go and do a secondary assessment, searching for secondary issues or problems that are not as life-threatening. And also, it depends on how long is your transport time. So by the time you en route, you might reach before you reach to doing this secondary assessment, where you're gonna do a full body scan or even focus on the secondary ear. Ensure your control of bleeding is maintained and note the injury location. So once it is a localized issue, you're gonna focus on the extremity, or we are talking about the face and neck. So you're gonna focus on those areas more in detail. If it's a systemic, or we consider that multiple areas are affected, then you need to be focusing on those in your rapid scan. In a responsive patient who has an isolated injury with a limited MOI, focus your physical examination on. So once the person is responsive and it's an isolated injury, then you want to focus on the isolated injury, the patient's complaint, the body region affected. So this is what we are talking of focused physical examination as against a full body scan if it's systemic or multiple system trauma. So these are questions you need to ask. Do the facial bones seem to be in alignment? Does the nasal bone seem to deviate from the midline? Does the mandible appear to deviate towards one side or the other? The answer to these questions will give you the index of suspicion that there is a fracture, some facial bone fracture. You're going to use your monitoring devices, and as for the advanced, you start with your pulse oximetry, your end-tidal CO2 capnography. Use non-invasive methods to monitor blood pressure, and ideally you want to get your first blood pressure manually. Use a glucometer to assess blood glucose levels. So you are gonna ensure that you do your full set of vital signs and address any treatment that is needed. So the last stage of the patient assessment is your reassessment, and this is not by the least. It is very important that you do your reassessment. Repeat the primary assessment. So basically, in your reassessment, you're gonna be starting over all that you have done already for this patient. You have not, your scene size up would have changed because you're more than likely will not be on that scene anymore. So you don't necessarily have to do a scene size up again. So you're gonna start from your primary assessment. So it is repeating your primary assessment. Check back on the patient LOC. You provided treatment. Has the patient LOC changed, improved, or worsened? Check back on your ABCs. Check back on the patient's vital signs. Check back on the chief complaint. Recheck patient's intervention. You had control bleeding, ensure that the bleeding has not resumed. We are providing oxygen therapy, ensure that the tank still have oxygen in it. Oxygen is still flowing. Ensure that the patient straps and the stretcher backboard are still secured. Maintain an open airway. Control any significant visible bleeding. If the patient has signs of hyperperfusion, aggressively treat for shock transport promptly. So it's very important that you do your reassessment, and you will reassess based on the status of your patient. A patient who is unstable, you will reassess every 5 minutes. A patient who is stable, you need to reassess every 15 minutes. Ensure that is being done. Communication and documentation is very important. So as you are leaving the scene, you should get your information together and inform the receiving facility of type of patient you are coming in with. Again, we say with these injuries, face and neck, patient might have to do surgery, and so it depends on the facility that you have available in your jurisdiction. It will determine whether they have in-house specialists or they have to call in persons to do what is needed. So the sooner you inform the receiving facility, it's better. And also you need to complete your documentation. Whatever you did, it must be properly documented. Document the method used to remove the patient from the vehicle. Again, the information, you are the eyes on the scene for the doctors. So whatever you see, you need to note it and can tell them so they can better appreciate what is happening. And especially in your history taking, whatever information, you need to get the information, because the patient might responsive at first. By the time they reach the facility, they might become unresponsive and cannot give any more information. So what you had gotten will be what is very important to the person that you're handing over to. So recognize, estimate, and report the amount of blood loss that has occurred. And again, that's an estimate you will have to judge. Call early to inform the hospital personnel about the various injuries involved in the patient's head and neck. Very important. Are we hearing, everyone hearing me still?
Yes, sir.
Okay, thank you. So we have looked at patient assessment generally. Now we'll be looking at soft tissue injuries. How do you provide emergency care for these injuries, as we're looking at face and neck? So your emergency care must focus on protecting the airway. You're gonna be using the mnemonic A, B, C, D, E. And we said if it's severe bleeding, it's gonna be X, A, B, C, D, E. So if deal with the exsanguinating bleeding, then you focus on your ABCs. If no exsanguinating bleeding, you will start with your A, B, C, D, E. Airway, breathing, circulation, disability, exposure. First, deal with your airway. The first thing that will kill a patient is if the airway is compromised. So use the jaw thrust maneuver to open the patient's airway and then suction the mouth. Control external bleeding by applying direct manual pressure. So generally for soft tissue injuries of the face and neck, this is the general emergency care we will employ in dealing with it. A, B, C, D is always gonna be the approach. Once you have an exposed part, always be mindful of it becoming dried out. So it is important that you cover the exposed part with a moistened sterile dressing. Then you will secure it with your bandages, and depending on where the facial injury or the neck injury is, you might not be able to apply too much pressure. So treat facial lacerations and avulsions as you would any other soft tissue injury. So just as in a abdominal evisceration, moistened sterile dressing, then you secure it. If it's for the neck, then you need to have your occlusive dressing. Check for bleeding inside the mouth. Broken teeth and lacerations to the tongue may cause profuse bleeding and obstruction of the upper airway. Again, it is make sure you have a patent airway and control those bleedings that you can as best as possible. Wrap portions of avulsed skin that have become separated in a sterile dressing moistened with saline and place them in a plastic bag in a cool temperature. So you don't want to freeze those parts. So never place tissue directly on ice. It is not to freeze them, but is to keep them cool until to preserve them. So where possible, they can be surgically replaced. As it relates to the injury to the eyes, this is the emergency care that you will provide. Once you provide the proper emergency care or treatment, it will minimize pain and help prevent permanent loss of vision. So in most cases, you will just need to provide supportive care, cover the eye with most cases a rigid eye shield if available, and then you will cover both eyes to prevent movement, because we know that you have sympathetic eye movement. If one eye moves, it will affect the next one. So you need to cover both eyes to prevent the unaffected eye moving and then cause further impact on the injured eye. So normal pupils are round, usually equal in size, and react equally when exposed to light. If we notice anything apart from that, as long as it's not something that the person was born with or had before, then you should suspect that there is injury to the eye and you need to take the precautions necessary. Abnormal pupil reactions sometimes are a sign of brain injury rather than an eye injury. So the injury, the impact to the eye can be as a result of something that has happened to the brain, but you might not be sure, so just take necessary precaution. Continuing treatment for the eyes when it's injured. Treatment starts with a thorough examination. So you're always gonna look, listen, palpate, observe, take care not to aggravate any problems. So you're not gonna be aggressively poking around or you can cause further damage. So you look for specific abnormalities or conditions. Irrigation with a sterile saline solution will frequently flush away loose small particles. So if it's believed that there is some foreign object in the eye, use your flushing, or if it has been exposed to chemical burn, you want to flush that chemical away. Continued injuries of the eyes. Foreign bodies may be impaled in the eye. Your care involves stabilizing the object and preparing the patient for transport. So at no times we are gonna try to remove that impaled object from the eye. It is to stabilize it in place. Gentle irritation usually will not wash out foreign bodies stuck to the cornea or lying under the eyelid. You might have to use your must be removed by a physician. Care involves stabilizing the object and preparing the patient for transport to definitive care. And as I said before, bandage both eyes with soft, bulky dressings to prevent further injury to the affected eye. So you can, if it's something under the eyelid, you can use a cotton tip applicator and gently remove it if possible. As it relates to burns of the eye, chemical burns, stop the burn and prevent further damage. Again, it's gonna come down to safety. So if they are not appropriately suited to access that patient in that situation where the burn or chemical burn occur, then you need to ensure that the patient is brought to you. So your safety is of consideration. Once the scene is safe, then the main thing is to stop that burning process and prevent further damage. So flush the eye with clean water or a sterile saline irrigation solution for chemical burns. We should, I would imagine, have that sterile saline or eye wash. If not, you just need to get some clean water and a minimum and flush the eyes. For the 5 to 20, continuous flushing is important, especially for the alkaline chemicals. Burns of the eye continue with chemical burns. Irrigate the eyes for at least 5 minutes. Follow local protocols and whether to try to irrigate while transporting or stay unseen, because certain, especially with the alkaline chemicals, there will be continuous damaging done to the eye layers and surfaces. It's going to continue to burn deeper and deeper as you go along. So your protocol will tell you if you should stay unseen and continue that flushing process, or you need to continue with it en route. So follow your protocol. Your protocol will guide you. And there we see impression of eye injuries, chemical burn. After completing the irrigation, apply a clean, dry dressing to cover the eye. Transport patient promptly to the hospital for further care. So once the person has been impacted with chemical burn, by right they should be seen for further evaluation, because we don't know what damage could have been done. Even though you have flushed it, it is advisable that they go in to get further evaluation. With thermal burns, and when we say thermal burns, we are referring to heat. Burning of the eyelids requires specialized care. So once a person is exposed to heat or fire, a normal reflex action is that they close their eyes, so the eyelid most of the time will be impacted from that heat. So best to provide prompt transport for these patients without further examination. So there's not much we can do there. Again, you can just cover it, both eyes, with a sterile dressing, moisten with sterile saline, and take the patient in. With light burns, infrared rays, eclipse light, and laser burns all can cause significant damage. So when we have solar eclipse, a lot of times we want to go and see it, but it can be dangerous, can be harmful to the eyes. So burn is not painful, but may become so 3 to 5 hours later. So that is why you might not even realizing that it's damaging your eyes until 3 to 5 hours later. That's when you start to have problem. Severe conjunctivitis usually develops with redness, swelling, and excessive tear production. Ease the pain by covering each eye with a sterile, moist pad and an eye shield. For lacerations to the eye, require very careful repair to restore appearance and function. So again, not much we can do than to provide supportive care. So apply no pressure to the eye. You don't want to go around poking around, and even when you're controlling of the bleeding, don't apply any pressure to the eye itself, to the globe. You can cause damage. If part of the eyeball is exposed, gently apply a moist, sterile dressing. Again, exposed part, moisten to prevent it from drying out. Cover the injured eye with a protective metal eye shield. So you want a rigid shield so that you don't cause any impact or pressure on the eye. It will shield it without applying pressure. And then you cover both eyes. Covered and cup or sterile dressing. You're going to apply soft dressing to both eyes. So after you have covered the injured eye with your rigid shield, you need to cover both eyes, because we said it can have sympathetic movement. One eye, the unaffected eye, will move and cause that injured eye to be moving also. On rare occasions, the eyeball may be displaced from its socket. Cover the eye and stabilize it with a moist sterile dressing. Never attempt to reposition that avulged eyeball. Blunt trauma. In case of high FEMA, and high FEMA is bleeding or blood in the anterior compartment or anterior chamber of the anterior compartment of the eye, so that is in front of the iris. Cover the eye to protect it from further injury. Again, not much we can do about that in the pre-hospital setting, rather than to cover it. And again, we need to cover both eyes to prevent one eye moving and affecting the injured one. Transport the patient to the hospital for further medical evaluation. With an orbit fracture, and this is the bone socket, bony socket that the eyeball is in, place the patient on a stretcher and transport promptly to the emergency department. Protect the eye with a metal shield, so the eye that is injured, cover with a metal shield, then cover both eyes to minimize eye movement. You have to remember that even though you have protected the injured one, if the uninjured eye move, it will cause movement of the injured one from what we say is sympathetic eye movement. Retinal detachment. This is a very serious eye injury, painless but produces flashing lights, specks, or floaters in the field of vision. Requires urgent medical attention to preserve vision. This is the area where the blood vessels and nerves that supply the eye should be connected, and if it's detached, then you know that circulation and nerve impulses will be affected, and the person stand the risk of getting serious permanent eye damage if not treated promptly. Eye injuries following head injury, possibility of a head injury if one pupil is larger than the other. For an unresponsive patient, keep the eyelids closed. Drying off the ocular tissue may result in blindness, so cover the lids with moist gauze. So again, it's just to provide that supportive care and recognize that from the eye injury, the person can have spinal injury, and protect the spine also if it's significant. MOI. Blast injuries management depends on the severity of the injury. If a foreign body is embedded within the globe, do not attempt to remove it. So treat it just as we mentioned for an impaled object. Use a clean cup or similar item to protect the area. If only one eye is injured, follow local protocol. So again, cover the affected eye with a rigid eye shield, and cover both eyes to prevent movement at all of the eyes. Contact lenses and artificial eyes. Never attempt to remove a lens from an eye that may have been injured. To remove a hard contact lens, use a small suction cup moistened end with saline. To remove a soft lens, place 1 or 2 drops of saline in the eye. Gently pinch the lens between your glove's thumb and index finger. Lift it off the surface of the eye. There's a case where you would need to remove the lens, and it's a case where you have chemical burn. If the lens is not removed, then you have the chemical beneath the lens can be causing further damage. So in that case, it is recommended that you remove the lens. So this is the case where you would, these are the methods by which you would remove the lens, depending on whether it's a rigid one or it's a soft one. Injuries of the nose. Nosebleeds are characterized based on the bleeding area. So anterior nosebleed usually originate from the area of the septum and bleed slowly. Posterior nosebleed are usually more severe and often cause blood to drain into the patient's throat, and that's where you have the major complication, and you might miss it because you're not aware that it's happening. And picture the inside of the nose itself to help in assessment. Assess all structures of the nose for injury. So that's the impression you have of the how it look inside. So you can have the posterior area that is bleeding, and that would end up in it, can potentially end up in the throat and cause airway obstruction. If it's more to the anterior section, then it will be bleeding to the outside. So epistaxis is bleeding from the nose following facial trauma can be severe and is most effectively controlled by applying direct pressure to the nares. So direct pressure should stop it. For the inside bleeding, there's not much you can do. Control bleeding from abrasions and lacerations to the nose by applying a sterile dressing. You can also put the gauze inside of the lip and apply the pressure. When it comes down to ear injuries, can result in sensory impairment and permanent disfigurement. If local pressure does not control bleeding, apply a roller dressing. And in controlling that bleeding, you want to place a dressing behind the ear and between the ear and the scalp, so it doesn't adhere to the scalp, and then you bandage it around the person's head. If the pinna is partially avulsed, carefully realign the ear into position. Attempt to retrieve the avulsed part for reimplantation. Do not remove an impaled object from the ear. Do not try to manipulate any foreign body in the external auditory canal. Again, that can make matters worse. You try to take out something and it can end up going further in. Signs and symptoms of a perforated tympanic membrane includes loss of hearing and blood draining from the ear. Careful assessment should be performed to detect and treat other injuries. And if there is what appear to be CSF coming from the ear, you want to, even with bleeding, you want to loosely control the bleeding because you don't want the pressure to build up. Facial fractures. What's gonna clue you in that there is a possible facial fracture is bleeding in the mouth, inability to swallow or talk, absent or loose teeth, loose and or movable bone fragments. So areas that should not be moving, you are noticing movement, then that should give you an index of suspicion that you have a facial fracture. And again, these injuries will look awful. Don't be distracted from the life-threatening situations and focusing on the that is just looking awful. Facial fractures alone are not acute emergencies unless there is severe bleeding. So you are looking at beautification or aesthetics. So plastic surgeon can repair the damage to the face and mouth if the injuries are treated within 7 to 10 days. Oral and dental injuries, blunt mechanisms typically result from motor vehicle crashes or direct blows to the mouth or chin. The primary risk is airway compromise from oropharyngeal bleeding, and that's the concern that we should be having. Possibility of that being compromised, the dentures can dislodge and go in the airway. Suction the oropharynx as needed and remove fractured tooth fragments to prevent airway compromise. Apply direct pressure to stop the bleeding. For severe oropharyngeal bleeding in patients with inadequate ventilation, suction the airway for 15 seconds and provide ventilator assistance for 2 minutes. So once the bleeding is continuing, then you're gonna have that sequence, 15 seconds, then 2 minutes of ventilation. You need to oxygenate or reoxygenate the patient. It depends on the situation. You might have to maybe go longer, but this is a guide. Deal with the situation as it presents itself. Leave impaled objects in the face in place and appropriately stabilize them unless they pose a threat to the airway. So if you need to provide CPR or you need to manage the airway and the impaled object is a problem, then it is when you need to remove it. When dealing with an avulsed tooth, handle it by its crown and not by the root. You don't want to damage those nerve endings that are there. Do not allow the tooth to dry. Notify the receiving facility. So again, you cover it with a moistened sterile dressing, place in a bag and put it on ice. And like we say, you don't want it to become frozen. Some protocol will tell you to put it in milk solution and other solution. But any airway, any injury to the neck is serious. So when it comes down to neck injury, so the structures involved in the neck and all of those structures can be compromised. So it's can become a life-threatening situation with a neck injury. Once the cartilages of the upper airway and larynx are fractured, they do not spring back to their normal position. Injuries of the neck can lead to loss of voice, the vocal cords are impacted, difficulty swallowing, severe and sometimes fatal ear obstruction, leakage of air into the soft tissue of the neck, and if you have leakage of air in the soft tissue, which is subcutaneous emphysema, you can also have possibility of ear embolism. If the veins are compromised, then it can be sucked into the vein and carried into the circulation. Subcutaneous emphysema is a characteristic crackling sensation produced by the presence of air in the soft tissue of the neck. Maintain the airway as best as you can and transport immediately. If the airway is very difficult to manage, consider paramedic support. An incident involving an injury to the throat may also have caused a cervical spinal injury. Spinal stabilization may be needed. So all of that would have been done from your scene size up. You would have suspected based on the mechanism of injury. Coming down, you would have taken those precautions early up in your assessment. Penetrating injury to the neck can cause profuse bleeding from laceration of the carotid arteries and jugular vein. Again, if you have, you will not attempt to remove an impaled object to the neck unless it affects your management of the airway where you will need to have it removed. Possibility of ear embolism gonna be very high. A large amount of air entrained into heart can lead to cardiac arrest. Immediately seal open neck wounds with an occlusive dressing. Use caution to avoid constricting the vessels and structures of the neck. Be alert for swelling and expanding hematomas. Again, that would be your indirect problem from the initial injury or insult. So be mindful of that. And that is why you need to continuously reassess your patient. Once you are controlling bleeding to the neck, you're going to apply pressure above and below the penetrating wound to control life-threatening bleeding. And if it's the neck, you don't want to wrap or bandage circumferentially. You will at no time create a situation where both carotid arteries are compromised, are compressed. So it will be from one side and go under the armpit and come back up with your bandage. Do not remove impaled objects while en route. Ensure airway remains open. Administer high flow oxygen. Obtain vascular access if needed. Provide your fluid station. Get your entitled CO2 capnograph reading. For laryngeal injuries, injury to the larynx can occur in case you have an unrestrained driver striking the steering wheel, snowmobile rider off or off-road biker strikes a clothesline or fixed wire. We call it the clothesline injury. Penetrating or impaled objects in the larynx should not be removed unless they interfere with cardiopulmonary resuscitation. Be mindful of that. Stabilize all impaled objects if they are not obstructing the airway. We can't overemphasize that. Signs and symptoms of larynx injuries you will observe are here: respiratory distress, hoarseness, pain, difficulty swallowing, which is dysphagia, coughing up blood, hemoptysis, cyanosis, pale skin, sputum in the wound, subcutaneous emphysema, bruising on the neck. All of these signs and symptoms should clue you in that there is possible injury to the larynx. How will you manage this injury to the larynx? Again, ABCs. Provide oxygenation and ventilation. So if it's a upper airway issue or it's a ventilation issue, then you need to provide that care. Positive pressure ventilation if indicated, supplemental oxygen therapy if that's what is indicated. Again, follow through with your entitled CO2 capnography reading. Apply cervical immobilization. Be alert to the need for frequent suctioning. Do not delay transport. Call for paramedic rendezvous for advanced air management, especially if the patient is apneic. So you're an advanced personnel. Remember, there is a limit to your scope. You need to, once you recognize that the situation is more than you can manage, you should have activated that call for the paramedic backup as soon as you realize it. And again, it's about your A, B, C, D, E. Most of the non-penetrating injuries are classified as sprain or strains. This is what you are talking about, muscular injury to the neck. Recommendation to transport patients to the ED for radiologic studies. So just as how you'd have a sprain or a strain elsewhere in any area, it's the same thing with the neck. You can have a sprain or a strain, and we know a strain is having to do with the muscles, tendons, and a sprain having to do with the ligament. So those in the neck can be affected, and you can have a sprain or a strain. Again, we won't know for sure. That's why you have to have X-ray radiologic studies. If you suspect musculoskeletal injury to the neck, then address any airway, ventilation, and oxygenation considerations. Pre-hospital management should focus on preventing further injury by restricting range of motion. Again, that's a treatment for sprain and strain. You go back to your rices. So you're gonna rest the area, apply ice compression, bandage it, and elevate splint. That's the normal treatment for a sprain and a strain, and it's the same thing if it's in the neck. Essential to check distal pulse and sensory and motor functions before and after the full body splint is applied. Again, that's the normal thing for any control of splinting. Any splinting procedure, know what it is before and after. Patients reporting neck pain should be evaluated for occult injuries and prevention of long-term consequences. So it is focused on the neck, but again, we say you can have spinal injury, and that will be dealt with when we come to head and spine trauma or injuries. But just focusing on the neck, be mindful of that concern. And as we look at the last slide, injury prevention. So everything in life, they say prevention is better than cure. So if all these injuries of the face and neck could have been prevented, then it would be better off for everybody. Some persons in the private settings might say, well, they want persons to get injured because it's better for business. But I'm sure as advanced personnel, we should be advocate for our patient, and we want to see reduction in injuries instead of more injuries. So prevention is very key. So what can be done for injury prevention? Helmets would help, face shields, mouth guards, and safety eyewear help to prevent injuries. So persons in the industrial settings, most recognized or properly functioning industrial setting would have these PPEs that you have to be wearing once you are in certain locations. Better occupant safety restraints and airbags help to prevent contact with the interior of the vehicle. Improvement to headrest reduce the number of neck strains. And this brings us to the end of face and neck injuries chapter. Any questions?